If you ever had pain, bleeding, or itching in your anal region, or you have seen blood drops on the toilet paper, you have probably already Googled it, and most of you have told yourself it's just hemorrhoids. But here's the problem: three completely different conditions share almost the exact identical same symptoms, and treatment for one might actually cause worsening of the other two. So please stay with me for a few minutes. In the next 10 minutes, I'll completely clear clinically how you can differentiate between these three so that you don't just end up buying over the counter creams, avoiding the right doctors, and getting worse with time, realizing that you spent months and years without getting treated, which could have been done in a few weeks. In fact, I'm going to give you the exact framework that colorectal surgeons and specialists use to differentiate between these three, even without examining or taking a look at the anus, so that you don't waste a single day treating something that you don't actually have and avoiding treatment of something that you do. Before going forward and breaking down each condition, I want you to know why this confusion exists in the first place. Because it is not your fault, it is a very common confusion. It's not stupidity, it's anatomy. The anal canal, the terminal space where you pass stool from, is a small pipe, a small space just 3 to 4 centimeters long or in length. And inside this space, multiple completely different structures exist side by side, including vascular cushions, mucosal lining, sphincter muscles, the skin, glands, and something that goes wrong in that region. Regardless of what goes wrong, symptoms tend to cluster around the same 5 kind of reactions that you present with. The most common 5 symptoms that you will have is bleeding from that area. Like I said, in the toilet paper, the amount may vary. Pain, itching in that area, discharge, and a feeling of something being wrong down there, either during passing stool or sometimes even later. Again, note down these 5 symptoms. These are the commonest presentation no matter what you have amongst the 3 common and sometimes even other uncommon conditions. And that is the bottom line. 3 different pathologies, but each expressing through the same 5 symptoms. And to add to that confusion, what makes it further worse is you can have one or more of these conditions at the same time. A patient with a chronic anal fissure can develop a secondary fistula. A patient with hemorrhoids can develop a fissure because of straining, and many of them overlap. They can coexist, and that is where it gets very confusing, which is exactly why getting this right matters so much. Because if you have a fistula and you are taking a hemorrhoid cream and trying to treat it, wasting your time, you are allowing a tract that connects your bowel to the skin to stay open, not heal, keep festering, and potentially develop a serious infection also. Now, let's start with the first condition, that is hemorrhoids or piles. To understand or believe that hemorrhoids is a disease is a myth. Hemorrhoids is not a disease you get. These are structures you have naturally in your body. Right now, as you are sitting, all of you, even if you're not bleeding, even if you don't feel anything, you have hemorrhoids or cushions. They are doing their job perfectly. What are hemorrhoids? These are vascular cushions, specialized clusters of blood vessels, smooth vessels, and connective tissue that sit inside and around your anal canal. Their job is to act like a seal, helping with continence control, ensuring that the anus closes completely at the right time. Every single human being has hemorrhoids, they are normal anatomy. The problem arises when they become enlarged, inflamed, engorged, and even displaced. That's what we mean when we say that this patient has hemorrhoids. We don't mean that they have the normal anal cushions, we mean that the hemorrhoids have gotten a little abnormal due to excessive blood flow, due to inflammation. They are either bleeding or jutting out and causing problems, the 5 problems that we discussed about. Now, there are something known as internal hemorrhoids, there are something known as external hemorrhoids, and the line that acts as a landmark and separates the two is known as the dentate line or the pectinate line, and it divides the anus into the upper 2/3 and lower 1/3. Anything above it is an internal hemorrhoid, anything below it is an external hemorrhoid. Most hemorrhoids, especially internal hemorrhoids, are painless. External hemorrhoids pain a lot. You must have heard of various gradings of hemorrhoids. Surgeons keep telling you have grade 3 internal hemorrhoids, and the grading is most of the times a clinical grading. Grade 1 just means that these are enlarged cushions that bleed but do not prolapse, so you will never know they existed except when you see blood on the toilet paper. Grade 2 is when they start enlarging and jutting out, prolapsing during defecation especially, but as soon as the defecation, the stool passing is over, they reduce spontaneously on their own. You might feel something momentarily coming out while you defecate, but then everything is fine once you're out of the washroom. Grade 3 is even after you have finished your stool passage, it is still prolapsing and you have to manually reduce it with your fingers. Otherwise, it's not going back on its own and you'll keep feeling something strange there. And grade 4 is permanent prolapsed, which you cannot reduce even manually, and this is where usually surgery conversation begins. So now that we know what hemorrhoids are, what are the grading, how they present, let's just see what the patient feels, what are the symptoms that they present with. The most common or the first symptom, I would say, sentinel symptom most of the time, is bright red blood, especially on the toilet paper or in the toilet bowl. It usually coats the stool. It does not mix into it or cause black tarry stools. It is fresh and it is separate from the stool coating it. The blood is typically painless with internal hemorrhoids. You will feel a feeling of fullness, you will feel a feeling of pressure. You will always feel a sense that the defecation isn't complete because there's that prolapsed pile which is making you feel as if still stool is there. Of course, sometimes the excessively prolapsed pile also causes extra continence, which makes you have that feeling. So first, you will see bright red blood with a feeling of fullness or pressure. Second, many times you feel itching, and which is caused by mucus secretion from the prolapsed tissue, which is irritating the perianal skin. So it is the perianal skin that's secreting mucus, but it's because of the irritation by the piles. But if it is external hemorrhoid or the existing internal hemorrhoids are clotted or thrombosed, they can lead to sudden, severe, sharp perianal pain. And you might even feel a tender lump, which is actually the clotted hemorrhoids or the external hemorrhoids. Now, there are a few things which causes this hemorrhoid to become chronic and to become worse. And they are constant straining, constipation, prolonged toilet sitting, low fiber diet, pregnancies, and of course a few medical conditions like portal hypertension, chronic diarrheas, even obesity, aging, and with aging the connective tissue laxity can lead to this. The common thread between all of these problems or predisposing factors is anything that increases venous pressure in the pelvic floor over a prolonged period of time can cause and will cause hemorrhoids. Now let us understand this hemorrhoids by the example of my patient. Sarah had been noticing blood on the toilet paper for almost 2 years. She was terrified. She assumed the worst. She googled it, used AI and realized that maybe this is cancer. Painless bleeding, anus, first thing comes up, cancer. She was too embarrassed as well as terrified to see a doctor. She brought every cream on the pharmacy shelf available over the counter. Sometimes it did heal temporarily and she thought maybe the bleeding is reducing, it will go away, but nothing could fix it. Finally, when she came in, we did a video proctoscopy and we realized it is grade 3 internal hemorrhoids, completely treatable. And she had spent the last 2 years in fear, anxiety, discomfort for a condition that had a simple, straightforward solution. And her biggest regret was the same, that I wish I could have gone to the doctor sooner and sorted it out, something that did not require such huge amounts of wastage of time and energy and anxiety, fear, etc. This is much more common than you think. And it starts with knowing what you're actually dealing with, what it actually is, which will require a short visit to the doctor, that's it. Now let's jump gears from hemorrhoids and shift over to a further common but difficult condition, anal fissures. Anal fissure is nothing but a tear, a split in the anoderm or perianal skin in the lower anal canal. The specialized skin that lines the lower anal canal below the dectate line, that is known as the anoderm. Just think of it like a paper cut, except the fact that this is in one of the most nerve dense, movement intensive locations in your body, meaning every time you pass stool, it's going to irritate that cut and it is very pain sensitive. Most fissures, if you imagine the anal canal to be a clock phase, occur in the 6 o'clock position, that is posterior midline. Why? Because the blood supply to that region is poor compared to rest of the anus. Less blood flow means slower healing, and a tear there can become self-perpetuating. It can keep worsening, becoming chronic, increasing with time. Fissures, depending on the onset, can be acute fissures or chronic fissures. Acute fissures, like the name suggests, is a fresh tear, usually from passing a very hard stool. When you look at the fissure, it shows bright edges, it bleeds, it's extremely painful. Typically, it can heal in 4 to 6 weeks if conservative management is done correctly. But a chronic fissure can persist beyond 8 weeks, sometimes months to years. The edges, because of the chronicity, have become fibrotic and indurated, almost scar-like. A classical feature is a tag of skin on the outer edge of the fissure known as a sentinel pile, by which doctors usually identify it. And that this was the outer side. The inner side has a hypertrophied anal papilla, but you don't need to go into technical details. When you see both of these, when a doctor sees both of these, he says this is a classic chronic fissure. They are often associated with internal anal sphincter spasm, and that spasm is both a consequence of the fissure and the reason the fissure won't heal. This spasm reduces blood flow further, perpetuating the ischemia and the low blood flow that prevents fissure repair. What does an anal fissure feel like? This is where the diagnosis becomes unmistakable, and I want you to listen what I'm about to speak. It feels like tearing, burning, cutting pain during defecation. Yes, patient describes it as a passing glass, razor blades or shards during passing stool. Genuinely one of the most intense pains in colorectal medicine. And then the secondary spasm pain starts. The act of defecation triggers the internal sphincter spasm. Post spasm, the spasm can last as long as 30 minutes to hours after passing stool. So the overall experience is painful defecation like the glass shards pain, followed by prolonged cramping, burning ache that slowly subsides only to return at the next bowel movement. Patients start dreading the act of going to the washroom so bad that they hold stool to avoid pain for days sometimes, which makes the stool even harder. And this only worsens the fissure and makes the whole cycle a vicious self-reinforcing cycle. And that's why the fissure never heals and becomes a chronic fissure in the first place. Now, the bleeding is not like the piles bleeding. It is typically very small amounts of bright red blood from the edges of the fissure, much less than the hemorrhoid bleeding. Most fissures bleed minimally and sometimes even negligibly despite causing enormous pain. There's no lump or prolapsed tissue that you feel, unlike hemorrhoids. Usually hemorrhoids as well as the fistulas and their perianal abscesses or infection do cause a lump. So this is much different. A fissure is a tear, not a mass. Please mind it. So whenever you have a tear and pain as the major symptom during defecation and follow up post that for a few minutes to hours, it's a fissure. But if it's a lump, maybe we are dealing with the other two things with relatively more bleeding. The pain would typically be located at the anal opening at the skin level, never deep inside like the hemorrhoid presentation or pain. So what does a fissure patient look like? I'll give you a diagnostic giveaway. If a fissure patient comes to me and tells me, "Doctor, the pain is worse right when I go for passing stool, and then it continues burning for an hour or two afterwards," that history tells me immediately that this is a fissure even before I have examined the patient. That post-defecation pain pattern, the prolonged spasm phase later, is pathognomic for anal fissure in our language. Hemorrhoids don't typically do that, fistulas don't do that. That pain is a signature which belongs to fissures. Why people misdiagnose this as hemorrhoids? Because this also bleeds, because there's perianal discomfort, of course, but the character of pain is completely different, which they are not aware of. Hemorrhoids produce heaviness, pressure, aches. Fissure produce sharp razor-like pain, burning, tearing pain, and specifically there is this distinctive delayed spasm even after passing stool, which lasts long. And here's the clinical consequence of getting this wrong. Hemorrhoid cream do nothing for a fissure. Worse, the petrolatum base in most creams can actually impair or stop fissure healing by keeping the wound moist and macerated. The correct treatment for fissure involves relaxing the internal sphincter with topical nitrates, a different kind of cream or spray, with calcium channel blockers or botulinum toxin injections. Surgeries are reserved for chronic refractory cases where it's not healing and the edges have become epithelialized, which is usually a lateral internal sphincterotomy, which helps relieve it. Completely different pharmacology, completely different target, different surgeries, which is why knowing the difference is not only academic but also therapeutic, and you should know. Let me give you an example of Mohammed, 28 years old, who was misdiagnosed for 14 months. Mohammed had been told that he had hemorrhoids by two different pharmacists and one GP because he never visited a specialist, all based on his complaints of rectal bleeding and pain. He used suppositories, creams, he changed his diet, nothing was helping. The pain kept getting worse. He finally saw a colorectal specialist and it took 30 seconds of history taking to tell him, "Oh, this is a fissure and not piles, you have been getting treated wrong." The examination confirmed a chronic posterior fissure with a sentinel tag and an internal papilla. 14 months of incorrect treatment and pain and misery. In 8 weeks with topical diltiazem, his pain resolved, he was cured, and that is why history matters the most than anything else. Now that we have covered these two conditions, let's jump to the third condition, change gears again, and this time go to anal fistula. Again, a common condition, but one of the most dreaded, or I would say relatively the toughest amongst the three. Now, what is a fistula? It's a tunnel or a tract connecting the inside of the anal canal or the rectum to the skin surface around the anus. You understand what's happening? There is a tunnel gone from your anal lining right up to the skin, but through areas it should have not gone. It almost always begins as a perianal abscess, meaning one of the anal glands gets infected, forms an abscess nearly at the level of the dentate line, and those glands get blocked. The bacteria multiply, the pus accumulates, and when the abscess bursts spontaneously or gets surgical drain, often a tract develops which goes right from that gland infection site to the skin, and this persistent tract is called the fistula. Think of it as a pipe that shouldn't have existed. It has an internal opening which is inside the anal canal and an external opening which is on the perianal skin. Between them, there is a tract with granulation tissue, chronically infected, epithelialized tissue also sometimes, which is constantly draining pus or stool, which it shouldn't have. Not all fistulas are equal. You will various times hear your surgeon telling you that you have an intersphincteric fistula or a transsphincteric fistula, and these are just anatomical subtypes. Fistulas always, I would say, require a colorectal surgical consult, and they should not be treated over the counter or at home. What does it actually feel like from your perspective, which we are here for? And this is where a fistula truly distinguishes itself from the other two. The hallmark of this condition is neither pain nor bleeding, it is persistent discharge. A chronic intermittent discharge of pus, can be blood filled, can be serous fluid filled from that external opening that you are seeing in the perianal skin, not from the anus, from the perianal skin a little away. Patients notice wetness, soiling of the underwear again and again, even bad odor. It doesn't stop. It can reduce sometimes but increase again, especially after a meal or bowel movements. Now, coming to a few red flags. If the patient tells me that they have had multiple perianal abscesses, drained in the emergency or the OR repeatedly, there is almost certainly that there is a fistula underlying each recurrence, and the abscess is just an acute phase, but the fistula is the chronic phase which is not being treated, although part of the same disease. The pain can be variable. Between flares, fistula can be remarkably painless, just wet and uncomfortable. You are seeing discharge or wetting of the undergarments, but nothing else. During an acute abscess phase, there can be severe throbbing, constant pain that is worse with sitting and defecation. Bleeding is not as prominent as hemorrhoids. With the discharge, which is more prominent, mucus and pus, there can be a little bleeding, but typically not dramatic toilet bowl bleeding, which is seen in grade 3 hemorrhoids. So the diagnostic giveaway is 3 words: chronic perianal discharge. Yes, if you have a long-term, maybe intermittent or continuous discharge of pus and mucus, not from the anus, from a nearby area, opening, a nodule or granulation tissue, that's a fistula. If patient's primary complaint is not pain and bleeding but persistent wetness or discharge from around the anus, think of a fistula immediately. No hemorrhoid causes persistent perianal discharge from an external skin opening. No fissure does that either. So it's very, very distinct from the other two conditions. Discharge from the external opening, that's the signature of a fistula. And why this is important not to miss, because fistulas do not heal on their own. Unlike fissures that might resolve with topical diltiazem, unlike hemorrhoids that might also respond to simple dietary changes or toilet habit change and even simple procedures, a fistula, the tract, usually doesn't close without treatment. Left alone, it can continue to drain, continue to risk infection, recurrent abscess formations, and rare cases, particularly in few immunocompromised states and conditions, can have further serious consequences. The treatment usually is completely a surgery or a procedure. There are various types of surgeries like fistulotomies, lift procedures, advancement flaps, set-on insertions, but this is a specialist territory and only colorectal surgeons should deal with this. No cream can address a fistula, no dietary changes closes the tract. It needs a surgical or an interventional specialist, and we should stick to it. Priya thought she was suffering from a recurrent hemorrhoid with flare-ups for almost 3 years. She was using suppositories, warm baths. Every few months she developed severe pain, and she saw her GP, who would prescribe antibiotics and diagnose it as a perianal infection. It happened 4 times in 3 years. When she finally got referred to a colorectal surgeon, the diagnosis was a transsphincteric fistula with recurrent abscess formations. 4 episodes of abscess, none of them correctly identified as a fistula recurrence. The fistula now was treated surgically, and now she is symptom-free from the past 18 months. 3 years of repeated infection, all from one misdiagnosis. Now that we have looked at the 3 conditions with a few patient stories also to help you relate and understand better why delaying diagnosis, delaying approaching a specialist makes it worse. Let me give you a single table that gives you the entire framework, so that before walking into a pharmacy or a doctor's office, you can ask yourself these questions. If you know someone who is suffering from this, you can ask these questions to that person and help that guy also. Now let me summarize it for you and ask you 3 questions which you can ask yourself. Question number 1: is your main issue bleeding, pain, or discharge? And this single question narrows it down immediately. In the comment section, just tell me, if you have bleeding, what's the primary diagnosis? If you have pain predominantly, what's the primary diagnosis? And if it's discharge, perianal, from an external skin opening, what is this? Second, what is the pain like? Is it pressure and heaviness? Is it sharp tearing pain that lingers for hours? Or is it throbbing pain that builds to a peak point which drains? And third, is there anything outside the anus? It can be a lump, which would be a prolapsed hemorrhoid. It can be a tear which you feel near or outside the anal opening, but it can be a small dimple or hole or nodule which can be draining and which can be a fistula. So I want to end the video with something very, very important. Everything I've just taught is designed to help you understand your body better, to walk into a medical appointment informed, to ask better questions, to stop suffering in silence if you're embarrassed or not wanting to go if you feel you have self-diagnosed. But I want to be very clear about something. Rectal bleeding always warrants medical evaluation. Not just once, not just with a quick Google search or a AI search, especially if you're 40, especially if the bleeding is new or changing in character. If there is any change in bowel habits, please understand you have to go to a colorectal surgeon or a specialist. Even colorectal cancer shares symptoms with all of these 3 conditions. So just because you've seen this video, don't say that I can diagnose any bleeding myself. No, you cannot replace, or this video also cannot replace a specialist advice. In fact, fissures and the related pain and bleeding can mask low-grade rectal tumors. Hemorrhoids can coexist with a polyp. So the examination by a specialist can reassure that it's benign and there's nothing that is getting missed or nothing serious. The conditions we discussed today are very common. They are treatable, but they need to be properly diagnosed, not self-managed indefinitely. I'm not saying that at any sign of a toilet paper, blood spot, or mild anal pain, rush to a doctor. But if there are any of the following symptoms, you should consider meeting one. If the bleeding lasts more than a week, or if it is recurring repeatedly, immediately go to a doctor. If you have a persistent lump that is not resolving, if there is discharge or recurrent infections around the anus, even if your doctor or GP tells you it's perianal abscess, no, meet a colorectal surgeon. If the pain is severe, not improving, you are over 40 years and this is a new symptom which you have not faced in the past few years. You have a family history of colorectal cancer, even without any symptom, you have to go for a screening. You now know more about this topic than most people who suffer for it through years. Use that knowledge. Don't let embarrassment or self-diagnosis be a reason to delay a conversation that could change everything. Now, if you found this video helpful, share it with someone who may need it much more than you also at this point of time. It might be the most useful thing they ever see this week and might actually help them with a lot of trouble that we discussed. If you have any questions about minimally invasive therapies like these conditions, including hemorrhoid artery embolization, where we can treat a patient with piles or hemorrhoids without any blade, without any sutures, without scar, without them having to remove their pants. Shocking but true. Then write in the comments hemorrhoid embolization and I'll make a long video on it and we'll talk about it very soon. Just for those of you who are in different countries, do not have an interventional radiology access, but having internal hemorrhoids, not wanting a surgery, dropping my number here where you can contact us on WhatsApp for a video consult and giving a link in the pinned comment too. Stay safe, stay empowered.